The topic today is palliative care, and that is going to affect every single person who is sitting here in the room today. Therefore, you all have a vested interest in how palliative care is going to be provided in this province. When your time comes, and that of those you love, you need to know that adequate services will be available to ease your suffering. Thank you very much for attending this public session today. We're going to be discussing the challenges that physicians face in delivering palliative care to patients in Newfoundland and Labrador. I'd like to remind everyone that the reason we are continuing to present these issues to the public is that we want the people to understand exactly what is at stake if we fail to address the problems in our medical care system. Our panelists today are Pat O'Shea, who will be discussing the challenges of providing palliative care while operating a demanding urban family practice, and Dr. Eileen St. Croix, who will be speaking to you about the difficulties of providing and accessing palliative care in rural Newfoundland and Labrador. I'm Dr. Susan MacDonald. I'm a palliative care consultant and divisional chief at Eastern Health for palliative care. I'm also an associate professor of medicine and family medicine at Memorial University, and I have a confession to make. I'm a CFA. I first came to Newfoundland as a medical student and spent several weeks out in Bayvert, and then moved down here to the old Janeway and spent another few weeks and fell in love with this place. And many years later, I'm not telling you how many, but I convinced my husband, who's also a physician, to move here to St. John's, and we've been here for 13 years now. I practice solely palliative care. I see patients in clinic. I see them on the wards of hospitals, in their beds at long-term care facilities and other places, and in their home. My job is to ease the suffering my patients experience and assist them in living the best way possible by providing the support and advice to the many physicians and clinicians who provide primary palliative care. I spend a great deal of time teaching junior colleagues and medical students and residents that the dying have value, and it's a gift to manage their symptoms and ease their suffering. Today you'll have an opportunity to hear from those who care for the dying on a day-to-day basis, understand the challenges and the rewards in providing this service, and to hear where the strengths and weaknesses reside. I'd like to start by reviewing exactly what palliative care is. There's a lot of confusion out there, sometimes even among healthcare professionals. The World Health Organization has the following definition. Palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. Palliative care provides relief from pain and other distressing symptoms. It affirms life and regards dying as a normal process. It intends neither to hasten nor postpone death. It integrates the psychological and spiritual aspects of patient care. It offers a support system to help patients live as actively as possible until death. It offers a support system to help the family cope during the patient's illness and in their own bereavement. Uses a team approach to address the needs of patients and their families, including bereavement counseling, if indicated. It enhances the quality of life and positively influences the course of illness. And it is applicable early in the course of illness, in conjunction with other therapies that are intended to prolong life, such as chemotherapy or surgery or radiation, and includes those investigations needed to better understand and manage addressing clinical complications. I'd like to make 2 points very clear. I'm not only speaking about cancer patients. Most people think of palliative care as only oncology. It's not. It's also very important to point out that and to acknowledge that palliative care is interdisciplinary. Nurses, social workers, physio, occupational therapists, dietitians, spiritual counselors, and volunteers, among many others, work hand in hand with physicians to provide the care. We physicians cannot do this without our many colleagues and the services and supports they provide. Palliative care happens all over the province. It's not just a ward at the Miller Centre. Patients might live their final days, weeks, or months at home, or sometimes in hospital wards, in long-term care facilities, and others. We strive to meet the patient where they are, both the physically where they are and mentally and emotionally where they are. There are challenges to caring for our patients in all settings. Our two panelists will discuss that further. Patients in hospital are often acutely ill. Decisions about care can change from day to day, sometimes, for some patients, even from hour to hour. And that leaves the patient and family confused and frightened about the future. Many patients are frightened to hear that they've been referred to palliative care because that acknowledges the need. If they acknowledge that they need us, it acknowledges what their future is. Sometimes the referral is very late in the illness and the patient is too unwell to participate in making decisions about their treatments and end-of-life care plans. Families are often distraught and find it difficult to hear what we have to say. They need time to process that information. But in a system of chronic shortages, time is the least available commodity. I see patients every day who want to go home to spend their last weeks or days in their own bed, surrounded by their own furnishings and the things that are important to them. But they can't leave hospital without a family doctor. The Community Health Palliative Care Program, which has been a significant help since it was instituted, only covers equipment and medication services for a short time. And not every patient can avail of that. Many folks I see have limited family in the province, and not everyone can leave work to care for a sick individual. I have to say, it is absolutely heartbreaking to sit at the bed of a patient in hospital and tell them about the realities of going home, knowing full well they probably can't do it. Weekly, we're faced with patients who have no family doctor and therefore no one to care for them. Many family doctors don't have after-hours availability or limited knowledge or experience in caring for this population. Not all graduates of Canadian medical schools have had any education in palliative care. And many of our foreign graduates who come to this province don't either. There has to be education and support on a daily basis for them. The day-to-day care of patients in the community falls to the family doctors, and you can imagine the kinds of discussions that we have to engage in and how those are not quick. It takes time to deal with the emotions that both the patient and the family are experiencing. Family doctors are often very pressured by a waiting room full of sick people, and all with several complaints that they need to talk about. And so you can imagine if you have to halt your clinic, run out to do a home visit for somebody who's in a crisis, knowing full well that when you come back, everybody has waited for a good hour while you've been gone. So you know you're going to be behind. As well, no physician can be available for patients 24 hours a day, 7 days a week, particularly for this population. And yet illness and death aren't 9 to 5 occurrences. So who cares for patients after hours? Here in St. John's, we've discussed the possibility of developing an after-hours cooperative group of interested family doctors willing to take on orphaned palliative patients and provide evening and weekend coverage for them. However, due to fee code inadequacies and a lack of an on-call stipend, we can't seem to get this off the ground. Several years ago, Eastern Health recognized the importance of palliative care and supported the development of a committee which reviewed how palliative care services were provided. We were tasked with the development of a regional plan. Now, that regional initiative has been finalized, accepted, and the leadership team should be put into place shortly. The overall strategy is to develop local teams in each community within the Eastern region, and each team will look after the patients in their community, and they will have support up the line. So there will be somebody that they can call who has a little bit more information and experience, working their way up to the tertiary care team here in St. John's, if required. We hope to develop policy and procedures to assist our community colleagues in coping with complex situations that they may be quite unfamiliar with, but that arrived in palliative care.